My presentation is visible.
Yes.
Okay. Well, I will be sharing my experience with this molecule. Although I don't have a very bad experience, so I will share the good ones. Uh, okay. Let's come to the first case. This was a 68-year-old male patient, a doctor himself. Had a complaint of blurring of vision for the last 5 months, and the vision was right eye 660 and the left eye finger counting 2 feet. Dilated fundus examination showed a bilateral CNVM, and you can see the OCT, the right eye active CNVM with the central macular thickness 341. The left eye was also an CNVM. Obviously, the prognostically this eye was not that good, and the CMT was 421. So this was the time actually a week back the Brolucizumab was launched, and we planned for the left eye accentrics. On the right eye, I had given an option of aflibercept and Brolucizumab. And this patient, being a doctor, went on through the pros and cons, and he actually went through the studies as well. And he decided to take Brolucizumab, and I was also very keen to see what the effect of this new medicine. Lucky for the patient, lucky for me, after a month of the first dose of Paganax in the right eye and the left eye eccentrics, you can see it's responded pretty well. In fact, the vision also improved from 660 to 636. And the left eye, as I said, it was not prognostically well. The SRF, obviously, the fluids dried up. The vision didn't change much with injection of eccentrics. And as we have seen in Hawk and Harrier, the loading dose, I followed the same sequence. So this patient was given 3 loading dose. This is the picture after the second dose, almost complete resolution of the membrane. And this is after the third dose. And the vision improved to even farther 618. And in fact, the patient was so happy that he insisted me to give Paganex in the other eye as well. Although it didn't show any changes anatomically, but somehow the patient was symptomatically better than the other eye as well. So this, if we summarize the first case, it was a treatment naive patient with 3 doses of Paganax actually improved from 660 to 618. And already 1 month we have seen in the follow up, he is doing fine. Coming to the second case, this was a 56-year-old female patient, dimness of vision in the right eye for a week's time, and it showed a subretinal bleed, and most likely it was an IPCV bleed. I can see the thumb like PED and the subretinal bleed. And this, by this time, I have already given 2 Peganax and planned injection Peganax for this patient. This patient was an outstation patient, so I was this time the Dr. Rajas came up, and there was a lot of discussion. I was very concerned about this patient, so I actually had seen this patient twice in the first week. And in the first week when she came, I thought, let me do an OCT and see what is the response. To my surprise, and within a week's time, it responded pretty well, and the patient from finger counting close to face actually had started seeing something like 1/6 vision had already come. And this patient, when came after a month's time, the vision improved to 660. And we decided for the second one. You can see after the second one, the vision further improved to 636. PD has decreased, and patient is symptomatically much better. And in fact, we have given the third dose to this patient. So if you summarize the second phase, this was also a treatment naive patient. IPCV bleed responded pretty well with 3 injections of Peganax. Third case was left eye CNVM or an IPCV. I will come to it. Why I have put oblique IPCV. This on presentation on 9th of June. This was the lesion, and he had undergone 3 loading doses of eccentrics and responded pretty well. And the vision also improved to 618. The problem came after 6 weeks after the follow up of third dose. That is, you can see here we have a notched PED. So most likely it might be a PCV lesion. That was a COVID time, so we were not doing an angiogram routinely. But definitely this lesion shows that it might be a PCV. And by this time, I have used quite many Peganax and was quite confident. And we have given injection to this patient and responded pretty well, and in a quick time actually. This was after 4 weeks, but patient actually responded pretty early than 4 weeks. The patient was symptomatically much better. So this was the third case. Summarizing this, this was a recurrence after the 3 doses of Accentrix, and following that 1 dose of Peganex improved to 612. Fourth case was similar to the last one. Here, the left eye had received 3 doses of Eylea, and the other eye was also a CNVM, but scarred CNVM, but received 1 dose of Accentrix. This was at presentation. And after 3 doses of Eylea, you can see the lesion is responded pretty well. The vision also improved. But here also the similar story. After 6 weeks, there was again a recurrence, and the vision dropped down to 660. And after giving single dose of Paganex 612, already this patient has, we are following up for more than 2 months, still maintaining, and there is no reactivation of the lesion. So this is the summary of the fourth case. This was a recurrence after 3 doses of aflibercept, and then we gave the Paganex and responded well. Coming to the last case, 78-year-old male patient, dimness of vision in both the eyes. Right eye was diagnosed with active CNVM. Left eye was a scarred CNVM. This patient actually was following with me for a long time, and he was getting the injection aflibercept, responding, but again after 4 to 6 weeks, some amount of fluid was coming. So you can say it was some sort of a refractory case. And after the 7 dose, I thought I will change the medicine and let's see what Brolucizumab do in this patient. And actually, it responded pretty well as far as the vision is concerned. Still, a little bit of fluid is there. So this is the entire list of my Peganex patients. Till date, I've given 20 injections. Three of that is a treatment knife. In all the patients, actually, it responded pretty well. Coming to the Indian experience, like Dr. Lalit was mentioning, now more than 1,000 patients has already got this injections, and only one case adverse report has been reported. And most of the indication is obviously AMD, but there are some off-label use in PCV, as I have already shown some cases of PCV, as well as in DME and CRVO as well. So coming to the take-home message, okay, it actually responded pretty well in all the cases, and the good part is it actually addressed all types of fluid: the intraretinal, subretinal, sub-RP, central macular thickness. And lucky for the patient, and lucky for me, no patient actually showed any signs of postoperative inflammation, whether it's anterior segment or a posterior segment vasculitis. Obviously, it is too early to say, but time will say whether this new molecule, Paganex or Brolucizumab, is safe and the most effective drug in the treatment of wet AMD and PCV. Thank you.
Thanks, Aniruddha sir. It was really nice, and I'm
I
very
think,
happy
uh,
that
I think this drug showing all the good results we have shown, none of your patient had any adverse effect event at all.
Right.
So does this become number one choice for you?
Frankly speaking, those who can afford, I'm giving this medicine as a first line choice. Although I give option all the anti-VEGF option, but seeing the effect and the way the medicine is working so fast, and the durability is also pretty good. So it has become my first line, at least until I get some adverse events.
I
Anand?
have
Anand?
I have a question. Do you take a informed consent about the 4% inflammation and 1% occlusive vasculitis? That's my question.
Uh, Actually, we are planning to put that in the consent form. Till date, we didn't have it. Although I explain whenever we are using these medicines, I do explain the pros and cons of this new molecule.
Because as an institute, we have decided that if a consultant is using, it should be with an informed consent. Because if in case of any kind of litigation comes, like it is not an informed that it is very well available. If you type in the Google, it's very well available.
Yeah,
ASRS
it is.
system.
Yeah.
So I think an informed consent is extremely important, and since
I
it's in
think the consent from
thousand injections, I would like to know how many of those 1,000 are single injections, how many have crossed 3 to 4 injections? Because I learned that most of this inflammation happen
second or
after the
third
third or
injection.
after the
Uh,
third injections. Yeah.
Yeah,
I have
because
multiple
basic.
injection in two of my patients, one 3 injections and another, the first patients actually got 3 injection in one eye and 2 injection in the other eye as well.
See, George, the
The
other thing
data
is
is
when
not there. How many is actually having multiple and how many are having only single injections?
so,
The
can I?
one thing I agree is that the rapidity of onset is there. You see, because it within 2 weeks, it does show an effect. So this is one of my patient, you see, where I had given this, and you see, my perception is that patients who have PED with fluid symptomatic, they seem to respond the best rather than the classic CNVM picture.
I
Because
think Hawk and Harrier study also mentions the same thing that sub RP fluid responds better with this new molecule compared
yeah,
to.
whenever you see, I have seen positive response. It is the RPED or like you're saying PCV with the fluid. This patient responded within 10 days, in fact.
I
No,
think that is
I
why
had
it's been
mentioned
shown
that.
to be non-inferior to aflibercept. I think that was the main criteria, and the main thing is that this is the type 3 hypersensitivity response.
Yeah,
So being a type 3 is not obviously going to happen in the naive patients. And other thing, as what George said about the consent, the problem is in the consent we have to say what options are available to the patients. So once we tell them that you have an option of Eylea or something else, and you tell them that this drug causes occlusive vasculitis, then how do you handle these patients? That's what I want to ask Aniruddha.
Now, actually, this has happened with me. This patient was also a physician, and I explained that there is a side effect of vasculitis. Actually, he refused to take it. So,
So I wanted to ask that, did you experience, aside the chances of inflammation and vasculitis, did you experience actual increase in treatment-free interval in some of your patients
yes,
which were
yes.
being treated before?
When I have used in the refractory case or a recurrent case, I already the time frame has gone near about 3 months, and they are maintaining pretty good. Like almost 2.5 months has passed away, and still the lesion is bright.
Okay.
My
And
thoughts on this is that, I mean, we have no doubt that it is efficacious. It's only about the safety issue. One thing which I'd like to point out is that, all the other drugs, the molarity is about 1 to 1.5 to 1.5. But this one has many times that. And it's something which the, Novartis and others actually pump up as an advantage, that we are giving so much more of the drug. Now, I think if a drug is supposed to be more efficacious, then less of the drug should be equally efficacious. You should have 1:1 modality. You're putting that much more drug.
But in
And
Hawken area, I think
primarily to,
3
yeah,
milligram didn't perform that well compared to the 6 milligram.
yeah, correct. So that is the paradox. So you're giving that much more of the active drug into the eye. Also, the most important thing is difference from the others is this is the only drug which is using a biosynthetic polymer, a scaffold. So in a way, there's a lot more plastic which you're putting into the eye, even if it's biodegradable. So perhaps nobody knows whether that's related or not, but it could be that
that
somebody
could be.
has an allergic reaction to that scaffolding and not the drug per se. So that's a moot point. There's something to think about.
So indirectly, Anand, you're saying if you increase the molarity of other drugs, similarly, they may be as effective as this particular agent?
That is to be seen. I don't think at least with Avastin and with Adisba, when they increased the dose, it wasn't seen to be that effective. This one's the dynamics is different. There's no doubt about that. It's more just like aflibercept shows PD flattening more than Avastin and Ranibizumab. This one does more, perhaps Eylea. But what I'm trying to say is that this is the only one which has the scaffold biosynthetic polymer going into the eye, and that many more times because the molarity is so high. So whether that has, it's a debatable thing, but it's something to think about.
Yeah,
Yeah.
to what Anand said, even they are looking at that actually, whether increased dose of the drug inside is, they are looking into that. So they are thinking whether these loading doses can be avoided, can be started from less, intense dosing.
Actually, it's a smaller molecule, 28 kilodaltons. So I think that obviously has helped them to increase the molarity.
So I think almost done and out of time. I think Jay had to leave. So I think on his behalf, I think I'll thank everybody for a fantastic session. Thank you, everybody. It's been a wonderful session. And thank you to AIOS and APBRS and IOC for putting this up together. Thank you very much.
Thank
Thanks.
you.
Bye-bye.
Bye.
Bye.
Thank you.
Thank you, everybody.
Bye, everybody.
Bye.